In this particular section, we are going to discuss on the non-Hodgkin lymphomas. Non-Hodgkin lymphomas is a huge topic, both in pathology as well as hematology, but I've tried to make it as simpler and as short as possible, even though it's going to be really long session. But anyways, the first thing we'll be discussing in the non-Hodgkin lymphomas are on the B-cell NHLs, because the B-cell NHLs are the ones that are going to be truly important, because they form 85% of the NHLs. I told you T-cell NHLs contribute only 15% of the NHLs, whereas B-cell NHLs are going to contribute approximately 85% of the non-Hodgkin lymphomas, isn't it? So let us see which is the most common. You can see this diffuse large B-cell lymphoma, which forms the major chunk and of course forms the most common type of NHL, and the B-cell NHL as well. And follicular lymphoma forms the second major chunk and the second most common type of B-cell NHL or overall in NHL. And next thing you have to know is what is the most aggressive type. It's the one that forms a small yellow chunk over here. That is the Burkitt's. This becomes the most aggressive of all the NHLs. I mean, especially in the B-cell NHLs. And if they ask you the most silent and the most indolent, is someone sleeping over here. So the CLL or SLL, a little common, not so common, but still this is the one that is going to be the most indolent of all. The most indolent of all lymphomas and the most aggressive of all lymphomas is going to be Burkitt's. Clear? So these all things we have to know about it. So after knowing the importance of this B-cell lymphomas, it's also after knowing the epidemiology of this B-cell lymphomas, it's also important to know some of the important features of this B-cell NHL neoplasms. So let us see what could be the cell type. First, let us put a small table-like scenario. So where I'll be writing on the cell type, because you have two types, B-cell as well as T-cell type, isn't it? So I will give some certain examples of those types, and let us put what could be the cytogenetics, really important for NHL from NHL point of view, and what could be the genetic mutations, gene mutations that you are going to encounter. So let us put a small table. So cell type, let us put mature B cell, because I told you we are not going to discuss the blastic lymphomas here. The mature B cell type. Next will be mature T cell type. Mature B cell type, you have a lot of lymphomas. For example, you have a Burkitt's lymphoma and leukemia. Then you have a diffuse large B cell lymphoma. In that itself, you have two types. One is called germinal center B cell type, and second one is called activated B cell type, called ABC type. Then you have a mantle cell lymphoma phenotype. Then you have a marginal zone lymphoma. I can write as MZL. This is a marginal zone lymphoma. Then I can write a hairy cell leukemia. Then I can write follicular lymphoma. And finally, I can write the CLL and SLL. The same thing which I have written previously. Do you remember in the lymphoma basics? So these are the different mature B-cell neoplasms, but what are the cytogenetics that are important? So the most important, obviously Burkitt's is really important. The most important cytogenetic change that's going to happen is T814 translocation, which means this 8 is very important in Burkitt's because it carries the MYC gene. MYC gene amplification is the cytogenetic risk factor for developing a Burkitt's. Apart from that, there are other things like C28, translocation of 28, and you also have a translocation of 8 and 22. So a lot of translocations are there, but you can see each and every single translocation involving chromosome 8, because I told you this c-MYC amplification is the characteristic feature of a Burkitt's lymphoma. Let us see what happens in the traditional thing. So you can see over here. So this is a very important thing to understand. So you can see the chromosomal translocation Burkitt's lymphoma. The usual and the most important is the 814 translocation, where this MYC gene is actually translocated towards this immunoglobulin heavy chain, where the immunoglobulin heavy chain and MYC gene will be combining with each other because of this. As a result of this translocation, as a result of this MYC gene will be amplified or over amplified, because MYC gene is a proto-oncogene, so it is going to increase the cell proliferation. It comes closer to the IGH. IGH is something having a heavy promoter effect, and it's going to amplify the MYC gene transcription and further translation. So MYC gene amplification is the important feature of a Burkitt's. Some example I'm telling you. Let us come back to the original one. So that's why I told you this MYC gene amplification, this chromosome number 8 where the MYC gene is present is very, very, very important for Burkitt's. And genetic mutations, so much genetic mutations are there which we cannot really tell what are genetic mutations. And what about this DLBCL translocations are not that important, but still one important thing to know is T1418 translocation for the germinal center B cell type and the 314 translocation for the activated B cell type. And all you need is to know that 14 is the very important value here, 1418 and 314. And what are the genes that are mutated? You have the CREBP genes, then you have EZH1 and MYC genes. So these are the most important genes, and here you also have the CREBP genes. Then you have genes that are related to NF-kappa B activation. So these will be activated in activated B cell type, because activated B cell type comes from plasmablast, I told you. So plasmablast survival, you need this NF-kappa B, which means plasma cell and plasmablast survive due to this nuclear factor of kappa B amplification only. That's the reason why multiple myeloma also is surviving through NF-kappa B, excess only. So any plasmablast and post-germinal center B cell, this NF-kappa B is a very important compound. So that's why in activated B cell type, if you go and see in the B cell base, I have told it arises from the plasmablast. So NF-kappa B is very important amplification. And CRBP is common between these two. And mantle phenotype, mantle typically it is not that important, but still it's important to know that T1114 translocations, and typically the genes that are mutated are BCL1 immunoglobulin heavy chain translocation will happen. So that's what is happening here, this T11 translocation. Your BCL1 and immunoglobulin heavy chain are coming close to each other, and because of that the BCL1 will be over amplified. Because of that your cyclin D1 dysregulation will be there, which means your cyclin D1 will increase, which moves the checkpoint easily, the cell cycle regulators. So this is very important again, this T14 translocation which amplifies the BCL1 and increasing the cyclin D1 expression by the cells. And marginal zone lymphomas, 3 characteristic mutations. You have T1118 translocations, then you have T114 translocations, and finally you have T14 and 18 translocations. Don't think too much about it, because 14, 18 can be present in both. So it's not like because a different gene can be translocated, it's not like what you think. So it's something quite different. But do remember this T11, 18 at least for exams, because this is an exam question. So what are the genes that are typically mutated? You have something called AP12 MALT1 translocation. This is a very important one. Through 11-18 translocation, you have AP12 and MALT1 translocations, and typically you have this BCL10 and immunoglobulin translocation, BCL10 and immunoglobulin enhancer, plus at the same time you might have this nuclear factor of kappa B enhancement. But this is not important for MALT, but this exam maybe they might be asking about this AP12 and MALT1 translocation, which is again a very, very important for developing this cancer. And hairy cell leukemia, you don't have any specific translocations, but majority of these patients are having this BRAF V600E mutation. BRAF V600E mutation, almost more than 99% of the cancers will have, hairy cell leukemia cancers will have BRAF V600E, again a very important exam point. And also very important exam point is this hairy cell leukemias tend to be trap positive on HPE, that is tartrate resistant acid phosphatase will be positive. This stain will be positive for hairy cell leukemia. Again, a very important multiple times asked question which we'll discuss in future in some time. So what are the things that you need to know? On hairy cell leukemia, again this T14, 18 becomes the most important, and always I tell 14 for follicular. So that's how you remember hairy cell. Burkitt's for 8. Burkitt's, how to remember? You have this kind of B when you write it becomes like 8. So that's how you remember Burkitt's for all related to 8, and c-MYC translocations and amplification. That's how you remember Burkitt's. And follicular you can remember 14 for follicular, very important. And what are the genes that are mutated? And this immunoglobulin heavy chain and BCL2 mutation, very, very important. This BCL2 over amplification is again an important feature of follicular lymphoma. At the same time, you might also get this MLL2 mutation. This is also possible. Very important again, both MLL2 mutations, again very important for your follicular lymphoma. And CLL and SLL, lot of things are there in cytogenetics. Deletion 13p is supposed to be the most common chromosomal abnormality in case of a CLL and SLL. Very important again, multiple times asked question. Most common cytogenetic abnormality in CLL and SLL is deletion 13p. And we'll see the importance of deletion 13p. Actually, it carries a good prognosis and favorable prognosis in case of a CLNSL, but in case of a multiple myeloma, it's going to carry a very poor prognosis. The same 13p if it happens in a multiple myeloma, but in CLSL, it's going to carry a reasonably good prognosis. And you have deletion 17p, and you might get something called a trisomy 12. All these things are again very important to understand, but deletion 13p is the most important as far as I know for exams. And the genes that are mutated are immunoglobulin heavy chains, especially the variable component of the immunoglobulin heavy chain, not the constant region. Next is ZAP70. All these things we'll see when we discuss about the CLNSL, TP53, SF3B1, ATM gene, and you might have other genes as well. But these are the most important. In that, I believe this ZAP70 and this immunoglobulin, sorry for that, this is ZAP70. So this is ZAP70 and immunoglobulin heavy chain. This tends to be the most common and very important mutation that is happening in this particular CLL and SLL cancer. So these are the very important mature B cell neoplasms. You have a lot of mature T cell neoplasms also which you have not characterized properly. For example, I can write here the mature T cell neoplasms. Only two things are very important for exams: mature T cell neoplasms or NK cell, T or NK cell neoplasms. So first one, I can write this peripheral T cell lymphoma, very aggressive neoplasm actually, this peripheral T cell lymphoma compared to, like in aggressiveness, it's very aggressive. And cytogenetics are absolutely non-specific, and the genes that are mutated are TET2 and DNMT3A. Like these genes are actually genes that are associated with epigenetics. If you see, these are DNA methylases, and TET2 is also an epigenetic change associated gene and protein. So all these things that are associated with epigenetic changes are associated with peripheral T cell lymphoma. And you have something called mycosis fungoides and Sézary syndrome. Mycosis fungoides and Sézary syndrome. And typically they are not associated with any much cytogenetic changes or not much genetic mutation that you can really take a note of and to tell it's important in real life as well as for exams. And you have something called anaplastic large cell lymphoma. Anaplastic large cell lymphoma, very important point is they are ALK positive. Very, very important. ALK positive, anaplastic large cell lymphoma, A4 tit for tat. Anaplastic large cell lymphomas are ALK positive. And you have angioimmunoblastic lymphomas. Again, there is nothing to be specific over here, cytogenetics as well as in the genetic mutations. Angioimmunoblastic, we'll discuss what are the features maybe in the later half of the video, but right now these are the very important. But the B cell lymphomas we have characterized in and out of all these things, and whatever I have told are very important. For example, T814 of a Burkitt and T1418 of your follicular lymphoma, and your 1114 in a mantle cell, and probably this 1118 in a marginal zone lymphoma. Then this c-Myc amplification in case of a Burkitt's, then this BCL1 immunoglobulin H translocation mantle cell, then your AP2 MALT in marginal zone lymphoma, and more importantly this BRAF V600E mutation in case of a hairy cell leukemia, and ZAP17 immunoglobulin heavy chain mutations in case of CLSLL. All these things are absolutely important for exams. You cannot go to the exams without knowing all these things, all this stuff. So anyway, so let us see some of the etiological factors. So etiological factor wise, you can think about the infections, which is a very common thing that are associated with lymphomas. First, let us see what are the viral infections and what are the bacterial infections, and finally you have some parasitic infections. Only one is associated with your lymphomas. That's what we need to know about. So first, let us see on the viral infections that are associated with the lymphomas, B cell lymphomas. So first viral infection is obviously the Epstein-Barr virus. Epstein-Barr virus associated with Hodgkin lymphoma. We have seen already Epstein-Barr virus infections associated with your post-transplant lymphoproliferative disorder. These are the B cell lymphomas that are associated with Epstein-Barr virus. Apart from that, EBV is associated with a lot of other lymphomas, like for example a Burkitt's lymphoma, that is also typically EBV associated. Some of the cancers, not all, some of the cancers may be EBV associated, and other cancers, if you want to know which are EBV associated, probably like the primary CNS lymphoma, which is also of B cell type, the primary CNS lymphoma in HIV patients, especially in HIV, not in non-HIV patients. HIV patients almost have 95% positivity for EBV if they get a primary CNS lymphoma. And nasopharyngeal cancers, obviously yes. Nasopharyngeal cancer is one of the important EBV-associated cancer. And gastric cancer is also one of the important EBV-associated cancers. As far as I know, which is up to my knowledge, I've told you all the EBV-associated cancers. So don't forget the nasopharyngeal cancers, very common in Chinese population. And HHV8, that is human herpes virus 8. Human herpes virus 8 typically results in something called a primary effusion type of lymphoma. Primary effusion type of lymphoma. Then you can get not primary effusion, it's a primary effusion lymphoma. I just wrote a short form. Then you have something called multicentric Castleman disease, and you might get a Kaposi sarcoma. All these things are HHV8 related. Multicentric Castleman disease and Kaposi sarcoma. Then you have something called HTLV1, very important and multiple times asked question in exam. HTLV1 is related to your famous adult T-cell lymphoma leukemia. Very important again. Multiple times asked question. Adult T-cell lymphoma leukemia is associated with HTLV1, human T-cell lymphotropic virus 1. Then hepatitis C virus is also associated with something called a marginal zone lymphoma. You know that HCV is associated with HCC, that is a well-known fact. It's also associated with something called a marginal zone lymphoma as well. And then bacterial, if you ask me, number one, H. pylori. H. pylori is the number one because it's associated with gastric maltoma. It's a very well-known fact. We have seen already about this in GIT section, gastric maltoma. Then Borrelia species is associated with cutaneous maltoma. Borrelia is associated with the cutaneous maltoma. And you have Campylobacter jejuni is associated with the small intestinal maltoma. And your Chlamydia psittaci is associated with the orbital adnexal maltoma. All these are associated classically with maltomas, orbital adnexal maltomas. And your Chlamydia pneumoniae is associated with the lung maltoma, and it also has a probable association with Sézary syndrome, cutaneous mycosis fungoides, with leukemic cells in the blood. We call it as Sézary syndrome. Anyway, probably associated with Sézary syndrome as well. And one parasitic infection is there, which I have not mentioned because only one parasitic infection, that is Plasmodium falciparum, has been shown to have a probable association with the Burkitt's lymphoma, especially of the endemic Burkitt's lymphoma type, probable but not very sure. This Plasmodium falciparum may be having association with Burkitt's lymphoma. Okay, so we are going to discuss about each and every single type of lymphomas from now on. So let us kick it on. So each and every single type of lymphoma. So what are the type of lymphomas you are going to discuss? So first let us group into indolent B-cell lymphomas and indolent B-cell lymphomas and aggressive B-cell lymphomas. First we are going to deal with the indolent B-cell lymphomas. If you ask me about the indolent B-cell lymphomas, it's the CLL and SLL, which I'm going to discuss separately because it needs a separate discussion. That is your CLL, chronic lymphocytic leukemia or small lymphocytic leukemia, that needs a completely separate discussion. Very important. Clear? At the same time, other indolent neoplasms which I want to discuss is, next thing is the hairy cell leukemia. Hairy cell leukemia. So, hairy cell leukemia, to be honest, let us see the epidemiology. It happens in men who are having middle-aged. Appearance of the cells will be somewhat similar to CLL, even though I will tell you some differences, but it will be somewhat similar to CLL, and it's got a reasonably good prognosis like CLL compared to other malignancies. At the same time, the clinical features, the patient will be presenting with symptomatic cytopenias. Because of anemia, they might have fatigue. Because of low lymphocyte count, they might be having infections. Because of the low platelets, they might have bleeding and all these things. At the same time, one of the important causes that produces massive splenomegaly. But remember, this is not associated with very important associated factors. This is not associated with any lymphadenopathy at all. Very surprising, isn't it? They have a massive lymphadenopathy. but they're not associated with any lymphadenopathy at all. And they will have symptomatic cytopenias. Any cytopenia can be there, or even a pancytopenia can be a presenting feature. And remember, one important thing, 20% of the patients may have leukocytosis also. But this is not an important thing for exam. The first three things which I told you are the ones that will be asked in exams. These are the characteristic exam related things. And in the peripheral smear, you can see typical and characteristic hairy cells. These are cells that are going to have irregular cytoplasmic projections, which I'll show you in some time. Once I finish this off, then I'll be showing the images as a whole. These are cells that are going to have irregular cytoplasmic projections. And in the bone marrow, you're going to see a particular type of cell called fried egg cells. In the bone marrow, you're going to see something called fried egg cells. Anything that has a clear halo, we call them as fried egg cells in pathology. So they also have something called fried egg cells in bone marrow, and it can be seen in many other conditions also. It's not specific for, this fried egg nomenclature is not specific for Harris leukemia. That's what I mean. It can be seen in many other places in pathology. Typically, they stain positive for TRAP, which means these leukemic cells will be TRAP positive, that target resistant acid phosphate, which I've told you already. And important CD markers that are positive will be CD103 positive and CD11C positive. Remember, this is really important. Both are very important. Especially the CD103 positivity has been asked multiple times about Harris leukemia, which I've discussed and I've highlighted a lot of times in the lymphoma basics also. CD103 positive and CD11C positive. At the same time, more than 99% of the tumors I told you, they will show this characteristic BRAF V600E mutation, BRAF mutations. And very importantly, I told you bone marrow is going to show fried egg cells, but this bone marrow is going to yield, if you do try aspiration will be going to yield a dry tab. So the moment you see a dry tab, you have to go for a trephine biopsy. Only in biopsy you are going to get this fried egg cell appearance. Apart from that, the bone marrow aspiration is characteristically dry tab, which means you're not going to get anything out of it. Clear? So these are some of the important features of Harris leukemia. We have a treatment in the separate section, which we'll discuss separately about the treatment of non-Hodgkin lymphomas, but right now this is enough. So these are important features. The next thing is the follicular lymphoma. So remember, what is the importance of this follicular lymphoma? Follicular lymphoma is typically second most common B-cell NHL and the second most common NHL overall. But if you ask me the most common indolent type of NHL, most common indolent non-Hodgkin lymphoma, or the most common indolent type of B-cell non-Hodgkin lymphoma, I will answer it's a follicular lymphoma, because follicular lymphoma is characteristically indolent in nature. It's very low grade and less aggressive course. It plays a low grade and less aggressive course. That's what is important to understand. At the same time, how the follicular lymphoma is going to present. It's going to present like very slow progressive lymphadenopathy, slow progressive and painless lymphadenopathy. Obviously it will be painless lymphadenopathy, and typically this lymphadenopathy will have a waxing waning course, which means they might increase and they might decrease in size. So they'll have a typical waxing waning course. Very important point. Typical waxing waning course, slow progression with waxing waning course, plus many patients also tend to have splenomegaly. Because it's an indolent lymphoma. Aggressive lymphomas present a little bit early stage, but indolent lymphomas tend to present later stage because patient tends to ignore because of absence of symptoms and the low grade nature of the tumor. So many patients tend to present at grade 3-4 at presentation. Many patients tend to have this disease at grade 3 and 4, which means stage 3 and 4 at, rather than calling grade, I can call it stage, isn't it? So they tend to have stage 3 and 4 at presentation and diagnosis because of the indolent course they have. And cytogenetics wise, if you ask me, more than 90% of the cases will have this T14-18 translocation, where you are going to translocate this immunoglobulin heavy chain with BCL2, which means there will be BCL2 overamplification, which means the moment BCL2 gets overamplified, that is going to decrease apoptosis, which means it's an anti-apoptotic protein, right? BCL2, you know that. So they are going to reduce the apoptosis. Typically, what are the cytogenetics? If you see, there will be CD5 negative and tumor cells, they will be CD10 positive. CD10, I told you, is the germinal center marker. So CD10 is germinal center marker. This is also referred to as CALA. This is called common ALL antigen, and CD10 positive indicates a germinal center origin, which means the follicular lymphoma tumor also originates from the germinal center. Very, very clear. So it's a germinal center marker, and they tend to be CD20 positive, and there will be BCL2 positive also. Remember, they might be BCL6 positive, that is not important. So, but they might be BCL6 positive as well. As we discussed the algorithm previously, I clearly told you this BCL2 positivity is a very important differentiating point of a follicular lymphoma. Clear? And they are BCL6 positive, there is no doubt about that, but this BCL2 positivity is very, very important. If they ask you what are the features that tell you it is a germinal center origin, the CD10 positivity, very, very important germinal center B cell marker, and this BCL6, which is also very important, equally important germinal center marker. So it is a germinal center B cell origin tumor. So that's what is very important. So BCL2 positivity is again a very, very important thing for a follicular lymphoma to understand. So what are the nodular, what you can see in the peripheral smear? In the peripheral smear, there could be presence of one characteristic type of cell that is called bud cells or buttock cells, which I show you. These are cleaved lymphocytes. These are cleaved cells. These are called as bud cells or buttock cells. This is not specific actually for follicular lymphoma. It can be seen in other types also, but for exams, the moment they give bud cells or buttock cells are cleaved lymphocytes in peripheral smear. These are leukemic cells actually. Some are shed into the blood from the lymph nodes, and these typically go towards a follicular lymphoma for diagnosis in exams. And remember, for scoring, we have a separate index for that is called FLIPI scoring, that's called Follicular Lymphoma International Prognostic Index. So this is what we use for prognostications to scoring system for follicular lymphoma. Apart from that, I think I have told you the most essential points, whatever it's needed, and the most important in this will be the T1418 translocation and this BCL2 amplification, and probably this CD5 negative, CD10 positivity, and BCL2 positivity and BCL6 positivity. This is the IHC finding of a typical finding of a follicular lymphoma. Then you have something called a marginal zone lymphoma. So we call MZL. This is called a marginal zone lymphoma. And generally there are three types of marginal zone lymphomas. You have something called a splenic marginal zone lymphoma. Then you have a nodal marginal zone lymphoma. Then you have extranodal, that is called a MALT lymphoma. MALT is a type of marginal zone lymphoma only. So how they present? Clinically, splenic marginal zone lymphoma is going to present like splenomegaly, no brainer. They're going to present splenomegaly only. This nodal marginal zone lymphoma is going to present lymphadenopathy, and again it's a no brainer, it's a nodal marginal zone lymphoma. And MALT lymphoma depends, and if you ask me what is the most common site for a MALT lymphoma, answer will be stomach, and they will be presenting with features like dyspepsia, bloating, fullness, abdominal pain, maybe depending on the site. That's how they're going to present MALT lymphoma. And immunoglobulin G will be positive for all these tumors. Immunoglobulin G, D will be positive, negative, it can be positive or negative, intermediate for a nodal marginal zone lymphoma. CD19, 20, 79A. All these things are positive for a marginal zone lymphoma, and CD5 will be negative, suggesting that this is not from B1 B cells, this is from B2 B cells. And CD23 again will be negative, suggesting, remember the CD5 and 23, these are two important markers to tell CLL and a mantle cell lymphoma. Mantle cell lymphoma. Why we are doing CD5 and 23 here is to show that it is not CLL, it is not mantle cell. Because in CLL and mantle cell, the CD5 will be positive, and in mantle cell it will be CD23 negative, whereas in CLL it will be CD23 positive. That's very important point. So CD5 negativity means you can tell it's not a CLL or a mantle cell. CD23 negative means you cannot surely tell it's not a CLL as well. And CD10 and BCL6 will also be negative. I already told you CD10 and BCL6 are very important germinal cell markers because CD10 is CALA, isn't it? Common ALL antigen. So Kala negative means it's not coming from the germinal center. That's what we're trying to tell, which means it's something not related to germinal center. It's from marginal zone. We told you already. It's not from germinal center B cell. Then cyclin D1 expression again is not seen in a like marginal zone lymphoma, because cyclin D1 is very important for mantle cell origin. The cyclin D1 overexpression is very common in a mantle cell lymphoma. So that's why we are clearly telling it's not coming from the mantle cell also. So these are some of the markers that you have to know. You do not know all the markers, typically speaking, for a marginal zone lymphoma. But one important marker that you have to know for a marginal zone lymphoma is CD43. This is very specific for marginal zone lymphoma. Majority of the marginal zone lymphomas will be having this CD43 positivity. So this is very important. So clear? So these are things that will help you to understand that a marginal zone lymphoma. Do you understand? Yes. And again, remember this gastric maltoma. I didn't tell you one more point. This gastric maltoma, this is stomach. If it happens in the stomach, this is what we call as a gastric maltoma. And this gastric maltoma has a strong relationship with H. pylori, which means one of the important treatment for gastric maltoma is just H. pylori eradication. That itself might cure majority of the gastric maltomas. And in splenic marginal zone lymphoma, in the peripheral smear, you can see some lymphocytes with cytoplasmic projections. These are not called as hairy cells. These typically are called as villous lymphocytes. Again, this is very important point. For example, this villous lymphocytes is a very important point. You can see this villous lymphocytes in peripheral smear. Clear? Especially in this splenic marginal zone lymphomas. And now we have seen some of the important types of indolent lymphomas. Then we'll move on to the Burkitt's lymphoma, right? So we'll be moving on to the aggressive types. We'll be moving on to the aggressive types of lymphomas. Aggressive types of lymphomas, the moment I talk about aggressive, next thing you have to know is the Burkitt's. That is the most aggressive NHL of all. It's the most aggressive B cell NHL. Everything, the price, the thing goes to the Burkitt's always. So let us see the Burkitt's. Even though it's not that common, it's very important to understand Burkitt's lymphoma. Number one, Burkitt's lymphoma, you have characteristically two types of Burkitt's lymphomas. One, you have something called a sporadic Burkitt's lymphoma. Second one, you have something called an endemic Burkitt's lymphoma. Sporadic Burkitt's lymphoma, typically they are located in the abdomen, and abdomen in the sense they tend to present as ileocecal mass, which means how they tend to present is like obstruction, intestinal obstruction. That's how they present. Bowel obstruction, ileocecal mass. But whereas endemic Burkitt's, they tend to present like a jaw mass, which means they will affect maxillary or mandibular bones. Jaw mass, maxillary or mandibular bones. So this is where endemic Burkitt's tend to involve. And EBV association with sporadic is only 20%, whereas more than 90% of the endemic Burkitt's are EBV associated. That's why I told you one of the important EBV associated malignancies is Burkitt's, endemic Burkitt's especially. More than 90% of the endemic Burkitt's are EBV related. And sporadic typically affects children as well as adults, but for exam's sake you can remember this typically affects the adults, whereas this endemic is going to affect the children predominantly. So you can see sporadic in adults, endemic in children. Clear? So this endemic Burkitt's also have a possible relationship with Plasmodium falciparum. I already told you this point before starting the different individual types of lymphoma. So endemic Burkitt's may also have an association with Plasmodium falciparum. And what are the other types? And third type of Burkitt's is there, which I didn't mention. I mean, this is not important because not given in many textbooks. So, but this is the third type of Burkitt that's given in many hematology textbooks. That is HIV associated Burkitt's. But it's rare, but HIV also can result in Burkitt's. This is called HIV associated Burkitt's lymphoma. This is the third type, which is not given in many textbooks, especially Your standard hardcore medicine textbooks will not give you this. Then, what are the translocations? I told you clearly the C814 translocation. This is the most common translocation. This is the most common cytogenetic abnormality seen in Burkitt's, affecting almost 75% of the cases, which will result in overactivation of the MYC-PRO-DONCO gene. Clear? So remember, and the Burkitt's most important cytogenetic markers will be, there will be CD10 positive and there will be BCL6 positive as well, suggesting they are coming from germinal center. So it's a germinal center tumor. Clear? And Burkitt's is something is a very highly proliferating cancer. So you have certain proliferative index like Ka67. Ka67 is supposed to be one of the important proliferating cancer proliferating index. These Ka67 values are extremely high. Usually it will be very high. Typically, whenever it is more than 90%, it is actually indicating a poor prognosis. It's very worrisome for Burkitt's, really. It's a very worrisome issue for Burkitt's. Whenever the Ka67, this Ka67 is also referred to as something called a proliferation index. Because being a very highly aggressive neoplasm, this Ka67 index tends to be extremely high in Burkitt's. At the same time, if you see in biopsy, what you are going to see in biopsy is typically, and the well-known fact that they are going to have something called a starry sky appearance. What do you mean by starry sky appearance? There will be a lot of sheets of tumor cells. A lot of sheets of tumor cells will be there, and in between you will have this scattered macrophages. These are called as stingible macrophages. These are called as stingible macrophages, which means lot of background intermediate. These are not large or small type of cells. These are medium cells, which I told you in the lymphoma basics, that are present. With in between you have these scattered tingible macrophages. These are called as tingible body macrophages. This is very important. These are macrophages that are stuck within this like malignant lymphocytes, and they have some ingested lymphocytes also with them. These are, and they're going for apoptosis. These are called tingible body macrophages. And remember, actually these lymphocytes are the ones that are forming the sky, and these are the ones that are malignant. Clear? And the tingible body macrophages themselves are non-malignant. Non-malignant. Why they call tingible body? Because they might show the ingested lymphocytes also. So they are non-malignant actually. This is exact reverse in case of Hodgkin lymphoma, where in Hodgkin lymphoma you will have the Reed-Steinberg cell, which is scattered here and there. That is the malignant cell, but whereas the background lymphocytes will be non-malignant. Clear? So they are reactive. So this is quite opposite to Hodgkin lymphoma. This is what we called as starry sky appearance. So these are some of the important things about your Burkitt's lymphoma. Let us move on to the next type of lymphoma, that is your DLBCL, that is called diffuse large B-cell lymphoma. As I already told you, this diffuse large B-cell lymphoma is supposed to be the most common, like NHL in adults. This is supposed to be the most common NHL in adults, and the overall most common NHL as well. Overall most common NHL as well. It's one of the aggressive types, not as aggressive as Burkitt's, but still it is aggressive. It's an aggressive neoplasm. And what is the clinical feature? How they're going to present? The clinical feature on how they are going to present will be by rapidly progressing painless lymphadenopathy. That's how they're going to present. Rapidly progressing painless lymphadenopathy. And because it's aggressive, it's going to present with like rapid progression of lymphadenopathy, not slow progression like follicular lymphoma. Plus majority of them will have B symptoms just because they are aggressive, and indolent lymphomas rarely have B symptoms, whereas this kind of aggressive neoplasms typically tend to produce B symptoms because they suck your energy out of your body, isn't it? So they cause a lot of hemodynamic and homeostatic alteration. That is the reason you get these B symptoms. Plus or minus very common extranodal involvement. Extranodal involvement is very common, typically seen in almost 40% of the cases. 40% of the cases. Clear? 40% of the cases will be having extranodal manifestations also. But anyways, so how will you diagnose is only based on the biopsy picture. So by doing a biopsy, you're going to see these cells express all the B cell antigens. that these cells are going to express CD19 positive, CD20 positive, CD22 positive, CD79A positive, that's immunoglobulin alpha, the 79A positive, then PAX5 positive. This also suggests that it's coming from the B cell origin, which I told you already, and it can express pan B cell antigens, but you have to characterize again, like what is the type of the like DLBCL. There are two types of DLBCL, to be honest. The first one we call it as germinal center type B cell DLBCL, and the second one we call it as ABC type DLBCL. ABC type DLBCL, that is called the germinal center type DLBCL, and ABC type DLBCL, or ABC means it's an activated B cell, whereas germinal center means it is a it's coming from the germinal center, typically from the centroblast. I already told you, when you draw the germinal center once again here, I told you these are centroblasts or proliferating B cells, proliferating activated B cells, these are centroblasts, and now they can go for selection or apoptosis. These are selected B cells, these are going to go for apoptosis. Certain B cells, these are pre-apoptotic B cells, which are pre-apoptotic B cells, and these selected B cells can become plasmablasts, which can become plasma cells, and this selected B cells also can go for formation of memory B cells. But the most important which I need to tell you is that this is the site of origin for germinal center B cell type DLBCL, and this is the origin for ABC type DLBCL, that is your activated B cell phenotype DLBCL. So this is where it originates from. So what are the differences? Differences is these are CD10 positive, Kala positive, this is CD10 negative, obviously, because it is from germinal center. That's it. It tells you it is coming from germinal center, Kala positive, I told you. And BCL6 positive, telling you it is coming from the germinal center. Here BCL2 will be positive, not BCL6 positive in fact. And here it will be MUM1 negative, here it will be MUM1 positive. And I told you the translocations also. The T14-18 translocation is the most common in germinal center B cell, whereas T3-14, but 14 is a magic number here in Burkitt's and follicular, right? So follicular lymphoma also 14-18 is very important. Here also this 14-18 is really important, but the gene translocations are quite different. So C14-18 again, really important. This reasonably carries a relatively good prognosis, reasonable prognosis, but this generally tends to carry a poor prognosis. Remember, this means germinal center origin. CD10 positivity means germinal center origin. Even there are certain algorithms have been devised to diagnose what is the DLBCL type. So for example, the most important algorithm is this. For example, see the CD10 first, whether it is CD10 positive or CD10 negative. The moment you call CD10 positive, it must be a germinal center B cell type. Is CD10 negative, still it could be rarely a germinal center B cell type, but I mean, this is the algorithm. So BCL6 is what you have to see. If BCL6 is positive or BCL6 is negative, remember if BCL6 is negative, definitely it must be ABC type, that is activated B cell, because it cannot come from a germinal center, because I told you BCL6 positivity is again a very important marker of germinal center. So it is an activated B cell type. If BCL6 is positive, then see the MUM1. If MUM1 is positive or MUM1 is negative, if BCL6 positive, MUM1 negative, it means it's a typically a germinal center B cell type. If BCL6 positive and MUM1 also positive, MUM1 positivity indicates a activated B cell type. Again, a very important algorithm to be known. And remember, CD10 positivity tells it's a germinal center B cell type, and MUM1 positivity tells it's a activated B cell type. And typically this BCL6 positivity also should tell it's an activated B cell type, but BCL6 negativity clearly tells it's a non-germinal center, that is activated B cell type. And morphological wise, there are 4 classes by WHO. Morphology means you see what the cell types you see on your eyes. in your histopathological examination. So morphologically, it is divided into 4 types. One is called centroblastic. Second one, you have something called immunoblastic. Third one, you have something called anaplastic. And fourth one, you have something called plasmablastic. These are the 4 types of DLBCL as per the morphology given by WHO. So this also it's better to understood. But this and all is not important. But actually the types of DLBCL are only these 2. That is germinal center B cell type and activated B cell type of DLBCL. And to be honest, there is an entity called primary CNS lymphoma. Primary CNS lymphoma. This is also a type of DLBCL only. This is also a type of DLBCL, and there is something called primary mediastinal B cell lymphoma. That is also a classified as one of the subtypes of DLBCL. Some books give a separate tumor, other books will give it a subtype of DLBCL. But definitely, primary CNS lymphoma, almost 90% of the primary CNS lymphoma are DLBCL of immunoblastic type only. It's DLBCL only. 90% of the primary CNS lymphomas are DLBCLs only. Then we can go to another aggressive tumor. To be honest, this tumor, we really don't know whether it is aggressive or not itself in the first place. Really, we have no idea whether it is aggressive or not. It's somewhere in between. That is called a mantle cell lymphoma. That's called a mantle cell lymphoma. We really don't know whether it is aggressive or not. It's not indolent also. It is not aggressive also. It's somewhere in between. That's why it's important to understand. So mantle cell lymphoma typically is a disease of older men. Very commonly affects men, but relatively older age, 60 plus usually, mantle cell lymphoma. And the most important translocation and the change that you get in a mantle cell lymphoma is this T11-14. Remember, 14-18 is either a GCB, DLBCL or a follicular lymphoma. But here you're going to get a T11-14. This is a translocation 11-14. Very, very, very important. Translocation of 11-14 in a mantle cell lymphoma. This is going to increase the cyclin D1 expression. Again, this is very important. That is why in marginal zone lymphoma, sometime back I told you, cyclin D1 is not expressed. That is rule out mantle cell lymphoma. The cyclin D1 staining is also very, very, very important for diagnosing a mantle cell lymphoma. This is seen in almost all the cases of mantle cell lymphomas. Remember, at the same time, your biopsy and immunohistochemistry is going to show typically CD5 positivity, suggesting it's not germinal center, it's a pre-germinal center B cell or it's a B1 B cell, CD5 positivity, and it is also CD23 negative tumor, because this is to rule out CLL, because CLL and SLL tends to be typically CD23 positivity. Here it will be CD5 positive but CD23 negative. Remember, it is CD22 positive, but remember again it rules out CLL because CLL is CD22 negative. Remember, CD5 positivity can be seen in both mantle cell lymphoma as well as CLL. Again, I am telling you, if you want to tell mantle cell lymphoma, it should be CD5 positive, CD23 negative, and CD22 positive. And if you want to tell it's a CLL, it should be CD5 positive, CD23 positive, and it should be CD22 negative. But the most important are these two. Very, 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 very important. CD5 and CD23. The most important for exams. And how they are going to show the characteristic histology wise, if you see, these tumors are going to show something called angular nuclei. As I told you previously, these butt cells are buttocks cells in follicular lymphoma, and you saw this kind of villous lymphocytes in peripheral smear in case of like splenic marginal zone lymphoma, and the hairy cells in case of a hairy cell leukemia. But here in biopsy, you are going to see something called angular nucleus. Very important point again. Angular nucleus is what you're going to see in biopsy. They're going to show this typical angular nucleus. And clinical feature is absolutely variable. Clinical features are very intermediate, and it's going to be varying, which means it can be very indolent, or it can be very aggressive, or it can be in between. A smoldering course is also possible. Smoldering means like asymptomatic, but it's growing. So that's smoldering. So you have a smoldering course also, very difficult to identify, and very difficult to determine the course of the lymphoma, and very difficult to treat also. At the same time, it has a very high relapse rate also. Very difficult. In general, it's very difficult to treat your low-grade neoplasms than high-grade neoplasms, I'm telling you. Because high-grade neoplasms in general, they are easy to treat, They are highly responsive to treatment, but they are having a worse prognosis. But whereas low-grade neoplasms, you cannot cure them. And there is no cure, but they have and response treatment also will be a little bit marginal, and they'll have a higher survival rate. That is different. But response to treatment and all these things are a little bit low in case of an indolent and low-grade neoplasms compared to high-grade neoplasms. So, and again, extranodal manifestations, very common. And here it is the most common site for extranodal involvement is the GIT. Very, very important point. I told you most common extranodal involvement in a usual NHL, any NHL is a bone marrow. But in this condition, it's the GIT. That's why it is very important. Extranodal involvement. Usually they can present with something called multiple intestinal polyposis. Multiple intestinal polyposis into susception or intestinal obstruction also. So this is very important point. So this GA involvement is very typical of a mantle cell lymphoma. Again, this is really important. In exam, if they give a lymphomatous picture with GA involvement, always think about a mantle cell lymphoma. That is really important to understand. Clear? This is an important external feature of a mantle cell lymphoma. They can have a bone marrow infiltration. I'm not telling no. Plus or minus they can have a bone marrow involvement and infiltration also. That is the reason one of the few lymphomas where endoscopy and colonoscopy should be performed, especially the colonoscopy, and endoscopy and colonoscopy should be performed as a routine staging procedure is this mantle cell lymphoma. Because in mantle cell lymphoma, you have to routinely do an endoscopy and a colonoscopy to rule out GA involvement. Because if there is GA involvement, it goes to a disseminated disease and stage 4. That's why endoscopy and colonoscopy is a very important routine procedure for a mantle cell lymphoma. Whereas other lymphomas, it's not a routine procedure, it's only optional. But here it's routinely, if you diagnose a mantle cell lymphoma by any lymph node biopsy, you have to routinely do an endoscopy and a colonoscopy. And prognosis is assessed by something called MIPI score, that's called Mantle Cell Lymphoma International Prognostic Index, whereas I told you for follicular lymphoma it's Philippi score, here it's MIPI score. And DLBCL I didn't tell you, it's simply something called IPA score as well, International Prognostic Index. This is useful for all aggressive neoplasms, aggressive lymphomas. But here it is MIPI score, which I'll discuss in some time what do you mean by MIPI score. Then finally you have something called primary mediastinal large B-cell lymphoma. It is often thought to be the DLBCL. It's a diffuse large B-cell lymphoma that is limited to the mediastinum. That is going to be limited to the mediastinum. Clear? So very important. So it's often thought to be DLBCL that is limited to the mediastinum. So it's going to present like a mediastinal mass. So clinical feature, they will be presenting like a mediastinal mass, typically an anterior mediastinal mass that is going to extend to local structures. So there will be a local invasion also that's going to extend to local structures, and very commonly they can present with SVC syndrome. They can present with pericardial and pleural effusions, and they can have associated local clinical features. Local clinical features like cough, shortness of breath, dyspnea we already told you, dysphagia, and hoarseness of voice due to laryngeal nerve compression, because these are all mediastinal structures that can be compressed, and because of that you might get symptoms. So these are the local clinical features. Remember, usually this mediastinal tumor, this tumor is associated with extensive fibrosis, high-grade fibrosis of the mediastinum. That is the reason why FNAC, you can't yield anything. Even if you poke a needle, if you try to aspirate, you will not get anything. So that is the reason why it is better to do mediastinal surgical biopsy. So because of that, it's always better to obtain a mediastinal surgical lymph node biopsy by Chamberlain's anterior mediastinoscopy is there. You call it Chamberlain's anterior mediastinoscopy, where you put a mediastinoscope inside, it's a surgical procedure, and you take a biopsy as such. Don't try to attempt FNAC because of the extensive fibrosis you have, and it's not going to yield anything for you. And sometimes the biopsy may resemble HL, that's Hodgkin lymphoma, may resemble this primary mediastinal lymphoma, large B-cell lymphoma. The reason is because primary mediastinal large B-cell lymphoma, also I told you they are going to show RS-like cells. Very, very, very important point. I told you, in Hodgkin lymphoma, I told you 3 things that have RS-like cells. One is like your primary mediastinal large B-cell lymphoma, second is your angioimmunoblastic B-cell lymphoma, and third is EB-associated mucocutaneous ulcers. We have discussed in the last video, Hodgkin lymphoma video. So RS-like cells are very characteristic, and they also confusing to the fact they also have weak CD30 positive. CD30 positivity. That is why sometimes you might confuse with the Hodgkin lymphoma, but it's not, because Hodgkin lymphoma and this NHL has a completely different treatment. So it's a disaster completely if you diagnose this as a Hodgkin lymphoma. But remember, on the other hand, they will have strong CD30 positivity. Hodgkin lymphoma patients will have, classic Hodgkin lymphoma disease patients will have strong CD30 positivity. So weak CD30 means it will be in less than 30% of the cells only will show CD30 positivity, but whereas here more than 80% of the cells will show CD30 positivity. That is what we called as like strong CD30 positivity. This is the one important thing to differentiate between a Hodgkin lymphoma and a primary mediastinal lymphoma. And also please do remember, DLBCL, it's a DLBCL only, but primary mediastinal lymphoma does not have any peripheral lymphadenopathy or generalized lymphadenopathy. That's a very important point. This is the one thing that this differentiates this primary mediastinal large B-cell lymphoma from systemic DLBCL. Again, a very important point. They don't have peripheral lymphadenopathy. They come purely as a mediastinal mass, anterior mediastinal mass, to be honest. So there are certain lymphomas which are very highly aggressive. They are called as double hit or triple hit lymphomas. Double hit or triple hit lymphomas. Double hit or triple hit lymphomas. What do you mean by double hit or triple hit lymphomas? Usually they have MYC translocations and MYC amplification. At the same time, they will be having one of the BCL2 or BCL6 amplification also, either this or that. Definitely associated with it, they will have a MYC translocation also. This is associated with extremely high aggressiveness and very, very poor prognosis. Extremely poor prognosis. If you ask me the most aggressive, I'll tell double hit or triple hit lymphomas only, but that's not a part of routine classification of a B-cell lymphoma. That's why I don't call this. Most of the cells will be absolutely undifferentiated, and they'll be, sometimes it's equivalent to that of the blasts, and there'll be very poor prognosis. This MYC with BCL2 or BCL6 amplifications, and this is what we call it as double hit or triple hit lymphomas. Clear? We are not going to discuss CLL now. At the same time, we are not going to discuss ALL, acute lymphoblastic lymphoma also now, because that will be discussed in the leukemia section. That is acute lymphoblastic leukemia in the first place. So with this, we can see some of the images. Before that, might be we can see some of the severity scores even before the imaging. Severity scores as such. So you have 3 severity scores. One is called the Philippi score. Second one, you have something called IPA score. This is for aggressive lymphomas like DLBCL and Burkitt's. Then you have something called the MIPI score. This is for mantle cell international prognostic index. Philippi is for follicular lymphoma international prognostic index. This is just an international prognostic index for aggressive lymphomas. So Philippi, remember the mnemonic given is no lash. I'm telling the features. The no lash is a mnemonic. So first one is more than 4 nodal areas. And second one, you have elevated LDH, and third one, you have age more than 60, and fourth one, you have Ann Arbor staging 3 or 4. Then next you have hemoglobin. This is stage, Ann Arbor stage 3 or 4, and hemoglobin less than 12 grams per deciliter. So these are the components of the Philippi score. May be asked in exam. So the mnemonic you can be using to remember this is called no lash is a mnemonic. Clear? And for international prognostic index, you have some features like stage 3-4 disease is common. Stage 3-4 disease is common here also. Then elevated LDH is seen here also, and age more than 60 is a feature here also. But apart from that, 2 different things are there. That's what you have to know. So in aggressive neoplasms, at least 2 extranodal sites. This is not 4 nodal areas. Extranodal, this is different from the Philippi index. At the same time, instead of hemoglobin, they are going to use something called performance status. That's called performance status. cancer performance status more than or equal to 2. Performance status score more than or equal to 2. These are the two different things from that of the Philippi score. You can remember this. And for MIPI score, it's actually a tabular form scoring system which is very difficult to understand. So I'm going to give only the features what is going to be based on. So one is the LDH will be similar. LDH will be similar. And actually the numbers are there which I'm not going to tell. And age is also there here. Then you have the WBC count. Instead of that, you have the WBC count. Then you have the ECOG status. You can write here maybe. You can have the WBC count and you have something called ECOG status. So these are the things that factors that are helpful in assessing the MIPI score. That is mantle cell lymphoma international prognostic index. So these are some of the important things that you have to know regarding the prognostic scoring systems. Now let us move on to the diagrams as promised, images as promised. You can see these are cytoplasmic projections typically that you see in a hairy cell leukemia. These are cytoplasmic projections that you see in a hairy cell leukemia. These are called as hairy cells. Clear? And you can see again in a hairy cell leukemia, you can see this characteristic fried egg appearance in bone marrow. You can see this is in the peripheral smear, this is in the bone marrow. Clear? Hairy cells. And remember, bone marrow will yield a dry tap again. This is a very important point in a hairy cell leukemia. And these are nothing but trap positive. Again in a hairy cell leukemia patient, all these are very important exam questions. Trap positivity, you can see this is the trap positive, this red color thing. And these are the bud cells or buttock cells that you are going to be seeing in follicular lymphoma, typically in the peripheral smear. Bud cells are the buttock cells in follicular lymphoma, and this is the characteristic thing that you see. This is called a starry sky appearance. You can see these are those tingible macrophages that you can see. These are the stars of the sky, tingible macrophages. You can see these are the stars in the sky in the background of sheets of lymphocytes, right? The background of sheets of lymphocytes, you can see certain tingible body macrophages, right? These are the tingible body macrophages that you see. Clear? So these are the stars in the sky. And here also you can see the classic starry sky appearance in low power, where you can see these are the tingible body macrophages in the background of sheets of lymphocytes. In the background of sheets of lymphocytes, you can see this very clearly. So these are the stars made of tingible body macrophages, very clear in low power, and the background is made of sheets of lymphocytes, which are the sky. So blue sky with stars. So this is a starry sky appearance that you're going to see. So these are some of the images that is really important to understand. So with this we are finishing the B cell neoplasms. So we can see some of the features of the T cell neoplasms also, some features. So what are the features of T cell lymphomas? T cell lymphomas. The important features of the T cell lymphomas, the number one, you have indolent or low grade T cell lymphomas. As we discussed already for B cell, we are going to differentiate into a indolent and aggressive variety. So indolent B cell lymphomas, number one, you are going to have mycosis fungoides and Sézary syndrome. Mycosis fungoides. This is one of the very, very indolent lymphomas. Typically, it is a T cell lymphoma only. It's a T cell lymphoma. Remember very carefully, the same type of cells, if it's limited to the skin and the lymph nodes, if it's limited to the skin and the lymph nodes causing lymphadenopathy, we call it as mycosis fungoides. The same type of cells, the same T cell lymphoma, the same cell type, if it's coming into the blood, which means it's a leukemic dissemination of the same T cells, leukemic dissemination of the same T cells. This is what we refer to as something called Sézary syndrome. Sézary syndrome. Clear? So which means additionally they might have skin as well as additionally they might have lymph node involvement. I'm not talking about that, but if these cells cause leukemic dissemination into the blood, that is what we refer to as something called Sézary syndrome. But the same group of cells, it's a cutaneous T cell lymphoma type only. Clear? So it's a T cell lymphoma only. Do you understand? Yes. So now, what are the clinical features? Typically, this skin lesions in mycosis fungoides and Sézary syndrome is going to come with erythematous and pruritic patches. Erythematous and pruritic patches. And usually, initially, the dermatologist tries to treat with standard treatments, and all the standard treatments will fail, which means this erythematous and pruritic patches will be refractory to standard therapies. Refractory to any treatment, any form of treatment. If I'm not talking about the cancer, initial basic conservative treatment if you give, they are not going to respond to that. And then only you suspect something is going wrong. Like how I told you for Langerhans histiocytosis, you get this skin lesions, which is initially rated like an eczema and seborrheic dermatitis, but will not respond to the standard therapy. Then you take a biopsy and diagnose it as a Langerhans histiocytosis. Similarly, the same thing happens here. This will be refractory to standard treatment. Then you take a biopsy and you can see that it is something, a cancer, a malignancy. Now, like they can also have associated erythroderma and alopecia. They can have associated erythroderma or associated alopecia is also a possibility. Remember, I told you lymph nodes involvement is very common, especially typically it will be local lymph node involvement, but they can have associated hepatosplenomegaly also. It's a very important point again. They might have an associated hepatosplenomegaly also. When you take a biopsy and see, they will look like atypical lymphocytes in biopsy. They will look like they are atypical lymphocytes. And if you stain them, they are nothing but CD4 positive T lymphocytes. They are nothing but CD4 positive T cells. And they characteristically have something called a cerebriform nucleus. Cerebriform nucleus or a folded nucleus, like brain like sulci gyrae will be there, no? That will be like folded nucleus will be there. This is called a cerebriform nuclei. That is due to clumping of the chromatin. They ask you why you see the cerebriform nuclei in this particular type of mycosis fungoides Sézary syndrome. You have to tell it is due to clumped chromatin. That is the reason why you get this particular type of cerebriform nuclei. Plus or minus, they will also, histology also will show something called a important feature called Poirier microabscesses. Poirier microabscesses. These are T cells that are infiltrating the skin. So these are T cells or that malignant T cells that are infiltrating the epidermis. This is due to epidermal infiltration, and those are referred by a special name called Poirier microabscesses. So you have to know how they present and what is the difference between mycosis fungoides and Sézary syndrome and how they present and what are these cells. Actually, they are CD4 T cells that are looking like atypical lymphocytes, and very importantly, you have to know that they are going to have this classical cerebriform nucleus, and they are also going to show this Poirier microabscesses in histology. Clear? Remember, the only thing that differentiates this mycosis fungoides from Sézary syndrome is the leukemic dissemination, which means if the cells are seen in the blood, it is Sézary syndrome. If you don't see them in the blood, that is mycosis fungoides. That's it. But both are one and the same entity. They are going to have skin involvement with or without lymph node involvement as well. Clear? So another, this is an indolent tumor, but you have a aggressive type of neoplasms also. Aggressive high-grade neoplasms also. One of the important aggressive high-grade neoplasms that you have to encounter is an adult T-cell lymphoma. It's a very aggressive tumor. Adult T-cell lymphoma leukemia. Remember, one of the important points that is, it's very common in Southeast Asian population and Caribbean population, which means it's not rare in our related and neighboring, our country and neighboring countries. So you can see a little bit of cases. It can be seen in a lot of Southeast Asian populations. It's an exclusive adult tumor. That's why it's called adult T-cell lymphoma leukemia. Clear? So it's exclusively, in which it's never seen in children. It's exclusively seen in adults. And another important point is it is HTLV1 related. We discussed this point already. HTLV1 has an important association with this adult T-cell lymphoma and leukemia. Then probably, like the oncoprotein, they might be asking this point also. The oncoprotein that is associated with this TAX protein. So this HTLV produces a protein called TAX protein, and that could be the reason for development of this adult T-cell lymphoma. Clear? And this virus can be transmitted parenterally through breastfeeding, vertical transmission, needle stick injuries, intravenous drug abuses, lot of areas this can be transmitted. So this is a typical parenteral transmission virus. Clear? So like HIV and hepatitis B, hepatitis C and all. So parentally transmitted virus. Then what are the clinical features? Clinical features, you have two types of clinical features. One is called acute presentation, and they may have a leukemic picture usually rather than a lymphomatous picture, and they tend to have a chronic presentation also. Usually this is less common. Typically they present with lymphoma like picture, lymphadenopathy like picture, and acute usually they will have a leukemic picture where they may also have additional hepatosplenomegaly. They will additionally have lymphadenopathy, plus or minus they might have cutaneous lesions, and they'll have a very, very high lactate dehydrogenase levels, and they also have hypercalcemia. Hypercalcemia is one of the very important paraneoplastic syndromes of acute presentations of this adult T-cell lymphoma and leukemia, which hypercalcemia may result in abdominal pain because of peptic ulcer like hyperparathyroidism. They can result in nephrocalcinosis, stones and groans, isn't it? Psychic moans, psychiatric possibilities, and bone lesions. Remember, all these things can also be seen in your hyperparathyroidism. So all these things can be seen, that is because of hypercalcemia. Clear not? So this is how they present. Usually this is a leukemic presentation where the tumor cells can be seen in the blood itself. It's more of a lymphomatous presentation where they present like a mild lymphadenopathy, that's all. They will not have anything else. Plus or minus they might have a very stable lymphocytosis. That's it. So this is the usual presentation of a adult T-cell lymphoma leukemia. So which means the only two things you have to remember: acute like a leukemic presentation and chronic like a lymphoma presentation usually. But which is more common if they ask you? Acute leukemic presentation is more common, and this hypercalcemia as a paraneoplastic syndrome is also very commonly asked question in exam, so you have to note that also. That's a very important point. Clear? And patients are highly immunosuppressed, and there is very high risk of opportunistic infections, because even though it's a malignancy, yes, but these cells are not functional cells, and they are also going to prevent the proliferation of the functioning cells, and they are going to create a lot of immunosuppression in the patient. And typically the markers will be CD4 positivity, CD25 positivity, but remember CD7 negative, CD19 and 20 negative. All these things are very important markers. And remember again, it's a CD4 T cell neoplasm. Clear? Like mycosis fungoides and Sézary syndrome, it's a CD4 T cell neoplasm. Again, important points: acute leukemic, chronic lymphomatous. Acute is more common, and it's going to be associated with the important paraneoplastic syndrome called hypercalcemia. And very importantly, they are CD4 T cell tumors. They are going to be CD4 positive and CD7 negative and CD25 positive. So these are the important things. And you have something called aggressive NK cell leukemia. Next one, aggressive NK cell leukemia. Aggressive NK cell leukemia. So aggressive NK cell leukemia is typically EBV associated and EBV related, and it has two types. One is called nasal type and second one is called non-nasal type. Typically how they will present is with constitutional symptoms, that is B symptoms will be there, plus multi-organ dysfunction, plus very importantly they are going to present with coagulopathy, that is DIC. And again, it's very important, there are few cancers which present with DIC. Hematological cancers, one of the important hematological cancers that presents with DIC that will be asked in exam is APML, that is acute promyelocytic leukemia, AML-M3. Clear? Otherwise called as APL or APML or AML-M3. That is the hematological cancer that you have to know that presents with DIC. Another hematological cancer that presents with DIC that you have to know for exams is this aggressive NK cell leukemia. That also can present with DIC and coagulopathy. Typically they present with B symptoms, multi-organ dysfunction with lymphadenopathy may be there, and coagulopathy is really, really important. And this malignant cells typically they will be CD3, 4, 5 and 8 negative, telling that it is not T cell origin, because CD3 is a pan T cell marker. So if CD3 is negative, CD4 is negative, 8 is negative, suggesting it's not a T cell origin. So CD19 and 20 will also be negative, suggesting it is not B cell origin also, which means then what are these tumors are? So CD19 is a pan B cell marker, telling you that it is not B cell tumor also. Then they will be positive for CD16 and 56, suggesting that they are originating from NK cell. It is an NK cell malignancy. It's a NK cell tumor. I told you SEXY16 are natural killers. So the natural killer cell marker. So CD16 and 56 positive. But remember, they can be positive for CD45 and they can be negative for CD68. Why I told the CD68 negative? It rules out it's not a histiocytic tumor. Remember, one of the important characteristics histiocytic marker CD68 we have seen already in the histiocytic and dendritic cell disorders very long ago. So this CD68 negative suggesting that it rules out it's not a histiocytic tumor. So this is the key for diagnosing this NK cell tumor. This is NK cell neoplasm. This is an aggressive NK cell leukemia. Then you have something called a large granular cell leukemia, that's called the LGL leukemia, otherwise referred to as large granular cell leukemia, which typically shows large granular cells in the peripheral smear or in the wherever tissue biopsy you take. But typically you will see in the peripheral smear because it's a leukemia. Because leukemia means the malignant cells will be seen in the blood. So typically LGL presents with a triad. LGL presents with a triad. What triad LGL has? Number one, they will have this typical large granular lymphocytes in circulation in bone marrow and in the peripheral smear. You're going to see. Remember, and at the same time, second, the patients will be having splenomegaly, which generally tends to be moderate to massive. Splenomegaly will be there. And third thing, the patient will have cytopenias. And the most common cytopenia is neutropenia. That is the reason why this patient is also highly prone for infections. Neutropenia. Very important. Clear? It looks like Felty syndrome triad, isn't it? If you remove this large granular lymphocytes from your picture, and if you add rheumatoid arthritis into that, you get the Felty syndrome, isn't it? Yes, true. That is the reason why it is associated with rheumatoid arthritis. Associated with rheumatoid arthritis, especially Felty syndrome. Remember, you might think it's a Felty syndrome, but if you see a large granular lymphocytes in the peripheral smear in a patient with rheumatoid arthritis, it doesn't go towards Felty syndrome, instead goes towards LGL syndrome. That's why it's very, very important point. And it's also associated with other condition called pure red cell aplasia. Pure red cell aplasia, almost 40% association with these things are there. So it's very important to note the association, rheumatoid arthritis and Felty syndrome as well as pure red cell aplasia. That's why I'm telling you, if you see the moment a rheumatoid arthritis patient is presenting with splenomegaly and neutropenia, do not straight away jump into conclusion that it's a Felty syndrome. Look for the large granular lymphocytes in the peripheral smear. If you don't see that large granular lymphocytes in the peripheral smear, then only you can diagnose Felty syndrome. Otherwise, it is an LGL syndrome. LGL syndrome also have an association with rheumatoid arthritis. Felty syndrome also has an association with rheumatoid arthritis. The only thing that separates your Felty syndrome from LGL syndrome that happens in rheumatoid arthritis is the presence of large granular lymphocytes in the peripheral smear and probably in the bone marrow as well. So that's why that point is really, 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 really important. Clear? And I told you there will be increased number of LGLs in the peripheral smear. Typically, it will be more than 500 per microliter. So normally, what is the normal LGL values? LGL is approximately 200 to 400 per microliter in the peripheral smear, normal population. And it contributes to 10 to 15% of the mononuclear cells. Whatever mononuclear cells you see in the peripheral smear, it differentially contributes to 10 to 15% of the mononuclear cells, and typically it is approximately normally 200 to 400, but if it exceeds 500, that is what we refer to as increased LGLs in the peripheral smear, large granular lymphocytic leukemia. LGL is actually very important in neoplasm. There are two types of LGL. One is called T cell LGLs and second one is called NK cell LGLs. Remember, very important, T cell LGLs will be CD3 positive, whereas and CD56 negative, whereas this NK cell LGLs will be CD3 negative but CD56 positive, which is a very important NK cell marker. Again, very, very important. Remember, CD16 is variable in this particular area. CD16 can be positive in both. So don't take CD16 here. CD56 is a very important differentiating marker here, and CD3 as well. So if they ask you why you get a neutropenia here, the reason for getting a neutropenia is a fast mediated death. The NK cells cause this fast mediated neutrophilic death, or it could be in rheumatoid arthritis is due to, but in Felty syndrome the mechanism is different. In Felty syndrome it is due to autoimmune destruction of the neutrophils. That is the difference. So in both these things I told you, in Felty also you can see neutropenia, in LGL also you see neutropenia. In Felty you get neutropenia due to autoimmune destruction of the neutrophils because of rheumatoid arthritis autoimmune disorder. Whereas in LGL syndrome, the neutropenia is due to fast mediated neutrophilic death. It induces death, this tumor cells. That's the difference, one more difference that you want to know. So LGL is over. So there are certain few other tumors of certain importance for exams. One is called anaplastic large B cell lymphoma. Anaplastic large cell lymphoma, that's called ALCL, anaplastic large cell lymphoma. I'll tell you the salient features. Typically they are CD30 positive T cells only. There will be CD3 positive also and CD30 positive, and there will be ALK positive. This is called anaplastic lymphoma kinase. That's called ALK. That's why the name came, anaplastic lymphoma kinase. This is called ALK positive. These are very important points, these two. This is the one that will tell you this anaplastic large cell lymphoma. And very importantly, this anaplastic large cell lymphoma, interestingly, they have found an association with females who are using silicone breast implants. Females who are using silicone breast implants. Clear? And this is a very interesting point, isn't it? That's why I told you that. And probably it is associated with one important translocation called T25 translocation. Typical presentation will be like lymphadenopathy plus or minus hepatosplenomegaly. They're going to present lymphadenopathy with or without hepatosplenomegaly. This is the presentation, but two most important points, CD30 positive, ALK positive. Maybe the silicone breast implant relationship is also one of the important points which could be a future question in exam. So then you have angioimmunoblastic type, which I'm not going to discuss anyways. Before that, I'll tell you one more type of NHL which is also very important, that is called HIV associated non-Hodgkin lymphoma. HIV itself is a very high and very important risk factor for developing non-Hodgkin lymphoma. What is the risk that imparted by HIV to generate a lymphoma is almost 60 to 100 times increased risk you are going to develop with HIV and lymphoma. And remember, NHL itself in HIV is an AIDS defining malignancy. AIDS defining malignancy. Remember, the moment they call AIDS defining malignancy, it is HPV-associated cervical cancer, then anal cancer, then Kaposi sarcoma, NHL. These are the four AIDS defining malignancies. NHL, cervical cancer, which is papillomavirus related. Then you have Kaposi sarcoma, again HHV8 related. Then you have that anal cancer. So these are the four typical AIDS defining malignancy, whereas one of the important AIDS defining malignancy is non-Hodgkin lymphoma, NHL. And the patient will have, different types of NHLs are there that will happen in AIDS patients. One is DLBCL. DLBCL, typically it will be of immunoblastic type. Which contributes to 70% in AIDS patients. I told you morphologically DLBCL has many types: anaplastic, immunoblastic, plasmablastic, centroblastic, isn't it? So immunoblastic is the usual commonest type of DLBCL you get in morphological picture, 70%. And second one, you have Burkitt's phenotype, Burkitt's lymphoma, that happens in 20% of the cases. And you can get with primary CNS lymphoma, that contributes to approximately 15% of the cases. And fourth one, you have something called primary effusion lymphoma. Primary effusion lymphoma, that happens in less than 5% of the cases. So these are the percentages that you have to know. These are the 4 different types of AIDS-related malignancies. Let us see some of the features, not all. So the DLBCL that happens is typically EBV related, number 1, usually EBV, Epstein-Barr virus related. Obviously it's opportunistic, isn't it? All these things, HIV is due to opportunistic, so typically it is EBV related. Then second thing, you're also going to get this lymphomas, especially if CD4 counts are less than 100. Very important point. And second thing, Burkitt's lymphoma, as you expect, it's not that EBV related, but EBV positive. Sometimes it might be EBV related. But remember, it can happen at CD4 more than 200 itself, which means even if the patient is not immunosuppressed, this tumor can happen. That is what the most important point in this is. Clear or not? So then primary CNS lymphoma, and again it is EBV related, and happens if the patient is having CD4 less than 50, usually, at very low CD4 less than 50. Clear? This is the one lymphoma that is also seen. Primary CNS lymphoma is also seen in patients without HIV also. DLBCL is also seen in patients without HIV also. Burkitt's is also seen in patients without HIV, and primary effusion lymphoma is also seen in patients without HIV. It's not like all these lymphoma are seen only in HIV. These are just age-defining malignancies, that's all. So again, this is EBV related, this primary CNS lymphoma, usually seen in patients who are having CD4 count less than 50. And one of the very, very important points that you have to note about this primary CNS lymphoma is the fact that it is the most common malignancy affecting the brain in intracranial malignancy in HIV patients. It's the most common, like intracranial malignancy. It's the most common brain tumor. It's the most common brain tumor in HIV patients, or it's the most common primary brain tumor in HIV patients. You can remember like that, or a most common primary brain malignancy in a HIV patient. Very important point. And the primary effusion lymphoma, typically it is HHV8 driven. Clear? HHV8 driven. It is associated with HHV. You can write with different color maybe. So this is typically HHV, human herpes virus 8. HHV8 driven. That's again, it's very important. Primary effusion lymphoma is HHV8 driven. So these are the 4 important AIDS defining malignancies that you have to know. I mean, AIDS related NHLs that you have to know that can happen in HIV patients. The most common being the DLBCL of immunoblastic type, which is 70%. Remember, this primary CNS lymphoma is also a type of DLBCL that also you have to know. It's not something separate, even though we put as separate. Ideally, the classification should be coming under the DLBCL only of immunoblastic type. So the next thing, we have to see some images. So these are important images that you have to show. So these are the villous lymphocytes. Ideally, I should have shown in the B cell neoplasms type. These are the villous lymphocytes. If you have a recap on where you see this villous lymphocytes, typically you're going to see in a marginal zone lymphoma. That's where you're going to see this villous lymphocytes. And these are nothing but mycosis fungoides, or it could be Sézary syndrome, because these are the characteristic red scaling plaques, isn't it? Red scaling and confluent plaques you are seeing. This is typical of the mycosis fungoides in Sézary syndrome. And you can see these are the typical portrait microabscess, epidermal infiltration of this CD4 positive T cells, portrait microabscesses. Very important image for exam. And again, you can see this is the characteristic cerebriform nucleus in a mycosis fungoides and Sézary syndrome in the peripheral smear. So this is seen in the peripheral smear. So this patient should be suffering from Sézary syndrome. Clear? Fine. So what is this? This is actually a typical large granular lymphocyte in the peripheral smear. You can see these are the large granules, and this is a lymphocyte, you know that. So this is a large granular lymphocyte in the peripheral smear. And this image tells you it is ALK positive. They give an image like ALK, they will not give positive. And if you show image like this, it means it's, see, you can see this brown thing. All these are ALK positive. So the moment you see ALK positive, this goes towards it's an anaplastic large cell lymphoma, in exams at least. So these are the important things that you have to note for exams. So important images. So finally, we are coming to a conclusion of all these things. It's treatment of NHL. What are the treatment aspects of a non-Hodgkin lymphoma? Non-Hodgkin lymphoma treatment, you can divide into 2 basically. One is indolent lymphomas. Second one is aggressive lymphomas. Aggressive lymphomas. Remember, indolent lymphomas, there's no cure. You cannot cure indolent lymphomas. It's a very important point. You cannot cure the indolent lymphomas, but they have high median survival. High median survival, which means a reasonably good prognosis. And you cannot cure. And the goal of treatment, whatever you give, the treatment goal is to reduce the symptoms of the patient. That's the main treatment. That's why if you understand the goal properly, you know why we are giving those treatments. Even CLL, when I'm going to discuss the next section, you'll understand why we are having this Binet staging, Rai staging, why you give only specific indications for treatment. Very indolent and no symptoms means you don't treat the CLL itself, just observe. But here it's not like that. I mean, in aggressive tumors, it's not like that. Aggressive treatments, it is curable actually. Probably, not all, probably curable. Probably curable, it might be cured, but overall it is having less median survival and they are having worse prognosis compared to indolent. Worse prognosis, but chance of cure is more. At the same time, the goal for aggressive lymphomas is cure. The goal is not to just reduce the symptoms, the goal is actually to cure the disease. This is the basic difference between treating an aggressive NHL and an indolent NHL. So let us see now what are the treatment options you have. The major treatment option, irrespective of whether it's an aggressive or a indolent lymphoma, is rituximab. Very important part of the treatment. It's a very integral part of the treatment, rituximab, because majority of the tumors will be CD20 positive. So that is the reason rituximab is a very important integral part of the treatment in any NHL. On contrary, your Hodgkin lymphoma, majority 95% are classic Hodgkin type, where rituximab will not be helpful because they are CD20 negative. That's one of the major difference. Rituximab is not helpful there, rituximab is helpful here, which I have seen already these differences in the basics of lymphoma section. And the treatment, initial treatment, what you are going to do. So let us see the initial treatment. Initial treatment that you are going to give in a case of an indolent lymphoma, you can just treat with radiotherapy. This can be used only for local disease, but remember, radiotherapy works little poorer in case of a NHL compared to a Hodgkin lymphoma, and it's not going to cure the disease. That's why in Hodgkin it's curable. It is not curable. That's why radiotherapy plays an important role in Hodgkin than non-Hodgkin. So radiotherapy only for localized disease. Second thing, you can use rituximab. Second option, plus chemotherapy. Rituximab plus chemotherapy can be used. What chemotherapy you can try? Like you can try agents like bendamustine. You can try any one, you can try, not all, because there is no point in treating the patient very aggressively and exposing them to side effects of these drugs. Any one you can use, bendamustine, or you can use other alkylating agents like cyclophosphamide, or you can use even a fludarabine. Other option that you can use is something called ibrutinib. Third option, you can use ibrutinib. Ibrutinib as a sole agent is also very effective for many NHLs, especially for CLL. Now it is considered the first line. Relapsing follicular lymphoma, you can use. Chronic graft-versus-host disease, ibrutinib you can use, which I have seen already. But one of the first line treatments of CLL and SLL right now is ibrutinib. That's why I'm telling ibrutinib as a very important treatment. It can be used as a first line in CLL now, as of now. But previously it was for relapsed CLL, but now it's for first line. And it can be used for relapsed follicular lymphoma also. Ibrutinib is finding a very large scale applications right now. It's a BTK inhibitor, we know already. Bruton's tyrosine kinase. So ibrutinib. So these are three treatment options. And other treatment options you have, you can use something called, instead of rituximab and chemotherapy, you can use alternative to rituximab is another anti-CD20 you have. And you know that rituximab is an anti-CD20, isn't it? Rituximab is an anti-CD20, we know already. And other anti-CD20 you can use like obinutuzumab. This is also an anti-CD20 alternatively. Plus you can use chemotherapy. But this obinutuzumab compared to rituximab is having relatively higher toxicity compared to rituximab. But is increasing the progression-free survival. It can increase the survival rates, especially the progression-free survival index. But in general, this is having more toxicity compared to rituximab. That's why we still stick on rituximab-based regimens. But ibrutinib as a sole regimen is also sometimes effective. And maintenance again, rituximab. Majority of the NHL's maintenance is based on rituximab. Once you finish the initial course of treatment, then maintenance will be done with monthly rituximab. This is very important again. And apart from that, there are certain other indolent cancers that have a little bit different treatment. One is the hairy cell leukemia. So one is the hairy cell leukemia, little different treatment. In hairy cell leukemia, the traditional treatment is fludarabine, and this is the most important treatment even now, fludarabine for hairy cell leukemia. Very, very important point. And also note that hairy cell leukemia, I told you, they are BRAF V600E positive. So this mutation is seen almost 100%. Now, more than 99% of the hairy cell leukemia will show this mutation. So you can give this BRAF inhibitors. BRAF inhibitors can be tried in relapsed or refractory disease. You can try this BRAF inhibitor. Typically, one important drug is that's called vemurafenib. You can try this drug. This is a BRAF inhibitor typically, so you can try this drug as well. Then second one, you have your gastric maltoma. So typically you need only H. pylori eradication. I already told you, I think I said a statement before, you just need a H. pylori eradication for a gastric lymphoma. Just plus or minus radiotherapy. This is needed only for refractory relapse disease, but you typically need only one thing, that is H. pylori eradication, which forms a major crux of treatment for your gastric maltoma. Then let us go for the aggressive treatment. I told you the aggressive NHLs, the goal is the cure. So typically the most important regime that you're going to use for aggressive tumors, aggressive NHLs is R-CHOP. Typically everything I told you. Rituximab is one of the core elements of treating NHL. So rituximab, and C stands for cyclophosphamide, and H stands for hydroxydaunorubicin, just to form the name they have created, which means hydroxydaunorubicin means it's nothing but it is just doxorubicin, that's all. Hydroxydaunorubicin. Then you have oncovin. The moment you call oncovin means it is vincristine. I already told you multiple times in ABVD regimen itself in Hodgkin lymphoma. And P stands for prednisolone. So these are the important regime. So remember, additionally you can give radiotherapy, especially if the disease is bulky. For bulky disease, for reducing the size of the lymph nodes, if it's symptomatic bulky nodes, you can use radiotherapy like what you have used for Hodgkin disease, but here it is not that important compared to Hodgkin. Clear? And there are certain things, because aggressive lymphomas, especially Burkitt's and DLBCL, there is a high chance of CNS dissemination. So you have to give prophylactic CNS therapy, or you have to give something called CNS prophylaxis. CNS prophylaxis is one of the very cornerstones of treatment in high-grade NHLs. Especially we will be treating with high-dose systemic, intrathecal or systemic methotrexate. We will be using intrathecal or systemic methotrexate. So what are the indications? Indications is number one, if the patient is having, first indication is at least 2 extranodal site involvement. This is one of the important features of a IPA score. Sometime back, if you take back and see in IPA score, International Prognostic Index scoring, I had given one of the important features is at least 2 or more extranodal site involvement. That's very important. Along with that, if you have increased LDH, definitely yes, you have to give CNS prophylaxis. Second thing, certain sites, certain danger sites. Danger sites, if they are involved, again it's very important to consider CNS prophylaxis with methotrexate, high dose intrathecal systemic methotrexate. So what are the sites that are dangerous sites? Paranasal sinuses, testicular involvement, breast involvement, periorbital involvement, bone marrow involvement, or paravertebral involvement. So these are also external areas only, but these are really, really high risk areas. If these areas even one is involved, you can consider giving CNS prophylaxis. So very important point again. So suppose if the disease is relapsed, for example, if it's an aggressive disease only, aggressive lymphomas, NHLs, relapsed or refractory disease. Suppose if the disease is relapsed or refractory, what you're going to do? First option is salvage chemo. As with Hodgkin lymphoma, you can give a salvage chemotherapy. Second option, you can give a very high dose salvage chemotherapy. high dose salvage chemotherapy plus immediately followed by autologous hematopoietic stem cell transplant. You can do that. And third one, you can try allogenic hematopoietic stem cell transplant, especially if there are 2 or more relapses. Beyond the second relapse, it is better to go for allogenic stem cell transplant after 2 relapses. So beyond 2 relapses, not the second. Beyond the second relapse, you can go for allogenic stem cell transplantation. But initially, you can try with salvage chemotherapy or high dose chemotherapy with autologous hematopoietic stem cell transplant. There is a separate section on stem cell transplant. We'll be discussing the later sections. But anyway, these are the treatment options. And there are new therapies that are coming. These are called CARTs. Clear? These are called CARTs. These are new therapies that are coming. So these are nothing but, what are CARTs? If you ask me, these are nothing but genetically engineered T cell receptors. Genetically modified or genetically engineered T cell receptors. These T cell receptors are designed in such a way that they target a specific and a particular antigen. That's what the idea is. So for example, in this case, you can use something called axicabtagene. This axicabtagene ciloleucel. I don't know how you're going to pronounce that. That's called axicabtagene ciloleucel. Or you have something called I don't know whether I'm really writing the correct spelling or not. This is called tisagenlecleucel. So that is how the pronunciation is supposed to be, but I really don't know that. But this I can easily pronounce because this is approved. That's called axicabtagene ciloleucel. So these drugs are engineered to produce, for example, here the T cell receptors are engineered in such a way that they are going to target the CD19 in the B cell, which means it's a pan B cell marker. It's going to target every B cell in the body. So T cells itself are going to destroy these B cells. But one problem potentially is these CARTs, when you give, they have a high risk of cytokine release syndrome. That's called CRS, because once the T cells bind with their respective antigens, they recognize that as an antigen and they're going to massively release the cytokines. So cytokine release syndrome is there, which can be sometimes life-threatening, and it's a severe inflammatory syndrome. That is possible with these CARTs, but apart from that, these are very important. This axicabtagene ciloleucel is actually approved for treatment for NHLs. So that's why it's very important. So these are genetically engineered T cells, this axicabtagene ciloleucel, that are directed against this, engineered T cell receptors to make that are directed against the CD19 pan B cell marker, axicabtagene ciloleucel. And for mantle cell lymphoma, for refractory or relapsed disease, mantle cell, I told you ibrutinib is one of the important option. Ibrutinib is one of the important option. For highly aggressive tumors, if they are relapsed, for highly aggressive tumors, if they are relapsed, for example, a Burkitt lymphoma, use something called an EPOCAR regimen. EPOCAR regimen. So what do you mean by EPOCAR? E stands for etoposide, P should stand for prednisolone. From NHL perspective, O obviously should stand for oncovin, and vincristine. C should stand for cyclophosphamide, we have been discussing for a long while, and H actually should stand for hydroxydaunorubicin, which is nothing but doxorubicin, and R stands for rituximab. There are also other regimens like Codoxium IVAC regimen. So this includes high dose cytarabine also. That's what this IV cytosine arabinocyte, that's what we call high dose IVAC regimen. So this Codoxium IVAC regimen, this also can be used, Codoxium or IVAC regimen. So all these things, but any Burkitt patient, they should receive CNS prophylaxis, because Burkitt itself, all patients should receive CNS prophylaxis in a Burkitt's lymphoma. All patients should receive CNS prophylaxis. Very, very important. Burkitt's is generally treated with EPOCAR regimen because it's a very highly aggressive neoplasm, and all patients with Burkitt should receive CNS prophylaxis, and also they should receive tumor lysis syndrome prophylaxis, because very, very aggressive tumor. Clear? So these are some of the important. So we have discussed two things. We have especially told about this mantle cell lymphomas. We have told a lot of things. So initially we are told aggressive lymphomas, how to treat. Then I told you relapsed aggressive lymphomas, how to treat. Then I've told you mantle cell lymphoma, ibrutinib, and highly aggressive lymphomas, especially Burkitt's, how to treat, IBOCA regimen. So as a nutshell, finally we'll put all the treatments of lymphomas, just the therapies. Hodgkin lymphoma, ABVD, plus or minus radiotherapy. For stage 3, stage 4 disease, you can use something called a BACOP regimen. Stage 3, stage 4, you can use a BACOP regimen. Stage 3 and 4 only, it's alternative. Alternative is BACOP regimen, but standard regimen is ABVD plus or minus RT. Like newer therapy, if they ask you new therapies, that is brentuximab, which you can use only for classic varieties. And if you ask me about rituximab can be used only for nodular lymphocyte predominant variety. But the treatment is ABVD with radiotherapy. Stage 3, 4 disease, you can try BCOP. And for NHLs, depending on that, rituximab is the important treatment. So if it's a low grade, you are going to treat with rituximab plus any one of the chemotherapy drugs like bendamustine and cyclophosphamide and all these things. And if it's a high grade neoplasm, then you are going to treat with characteristic R-CHOP regimen. And if it's mantle cell lymphoma, you are going to treat with ibrutinib. It's a very important treatment. Then if it's a highly aggressive tumor like Burkitt's, typically you are going to treat with a IBOC-R regimen. And the newer drugs here which you can use is something called obinutuzumab for NHL. Typically you treat for low grade NHLs instead of rituximab. And you have CARDS, absicaptogene, ciloleucel. So I told you already. So these CARDS are also newer therapies. So these are the final nutshell summary for treating a non-Hodgkin lymphoma. I told you, I think we have covered in detail about all these Hodgkin and non-Hodgkin lymphomas. Now only one thing among the Hodgkin lymphomas is there, non-Hodgkin lymphomas there, that is CLL, SLL, because since it's a leukemia also, we have kept for a separate discussion, a small discussion on that. So I think we have covered in everything about the NHLs right now. So see you in the next one.